The case. So, like I said, she was referred to us. Came for a second opinion. Basically, she was a 62-year-old female. She was a diabetic for 25 years. She was on oral hypoglycemics, and she was also hypertensive. She had nuclear sclerosis grade 1 and 2, and the fundus picture was something like this. We can say roughly that this was more of a case of a severe NPDR. I'm sure all of us, regardless of what specialty, but we do the next step, which will be the OCT. The OCT showed in the right eye, it had an ERM along with diabetic macular edema, along with SRF, and the left eye as well had cystoid spaces, SRF, along with thickening. The vision in the right eye was counting fingers 2 meters, and the left eye was 636 parts. Now, it's a basic question, sir. Manangat sir, what should be the next step for all of us in this situation? Because the patient has come to us for a cataract. The patient was actually counseled for a multifocal IOL. Which is often the case, which retina specialists land up getting, that you have a multifocal IOL and you have to convince this patient. So what should be the takeaway here, sir?
Well, the first question is no multifocal IOL. You have to very thoroughly convince the patient that multifocal IOL is going to be totally out for a situation like this, yes, whatever it may be, because their outcome is going to be so poor otherwise that it's going to be a problem later on. So that is out. But the question here is that it looks like that it's not only having a issue in the eye, maybe systematically also there's a lot of issues, because we see a subretinal fluid also in both eyes, and massive edema, and the type of retinopathy, the retina with the way it's seen. I would like first to also have a systemic evaluation where you do all the tests, not only that you're going to do blood sugars, lipid profile, also 24-hour urine protein, as well as also looking at HbA1c. All those parameters are very important, because so why it is important.
So the urine protein is something that I had heard you say last time as well, because that's something which we don't do it in regular
That is
practice,
why we've been emphasizing from our center that very much. The problem is we always do blood urea serum creatinine, which takes so long. When the kidney is damaged, it is a parenchymal damage, then those parameters would rise. It's the initial would only be microalbuminuria, and it will come best with the 24 hours urine protein. If you do that, you'll get how much protein is coming, and there are good medicine these days that you can at least, if not improve, but further it can be sort of halted, or slower progression would be there, because that will also contribute to this as well as patients' other morbidity. So doing just blood urea and serum creatinine is not at all in the beginning. That will always be normal and give a false hope to the patient as well as to the doctor. So this is my request to all the cataract surgeons: at least get 24-hour urine protein. That is what is required, and no multifocal IOL here. Yes. And of course, once we have done that, then the way we go here is definitely we would like to evaluate, is this area ischemic? You can do OCTA, you can do otherwise angiography, but OCTA these days most of the time reveal all. And first line therapy, even if there is these days ERM, we do try anti-VEGFs. So that is the way we go. But in case the cataract is now much more, and cataract is significant, then what we have been doing, and together with Professor Jagatram here, then we would like to use Ozurdex in a situation like this, and get everything down, and 3 months as well as you'll get a good outcome. But use a monofocal IOL.
Correct. Sir, so another question would be, which eye would you operate? Because the patient complains that the right eye has been bad for a while. She came because the drop in vision was in the left eye.
That's what I'm saying, that the left eye would be more concentration. Correct. It appears that the right eye may be going on for quite some time.
Correct.
Things. The way the left eye appears, it is something which has happened now. It could be because of the systemic issues as well as the other issues. That's why those tests are important. And secondly, we would like to give here, if the cataract is not that significant, then we would like first to treat with anti-VEGFs. Okay. And so once it becomes flat, and then we decide accordingly. If it is totally flat, then the situation is different. But otherwise, most of the time, we try to give Ozurdex and do cataract.
Because, sir, our cataract colleagues are very eager to be operating, So that's the key takeaway,
that,
even if
you
have
they
to ensure
want to
that the edema kind of settles.
Even if they are eager, then use Ozurdex. That is what I would advise. Use Ozurdex, because here, if you just give one injection, it's not going to be enough. And by the time, the normal time after cataract surgery, for the whole thing to come back and super add on to this is usually after 6 weeks. It is from 2 to 3 months when it comes back. And that is not covered by your injection. So that is what happens. Yes.
Correct.
So give Ozurdex.
Correct. Okay. So I'll just one last case. This would be a case of a 56-year-old male who was a diabetic for 6 months, hypertensive for 10 years, underwent cataract surgery in May of 2022. This was a presentation of the OCT about 3 months later. What should be the next steps, sir? Because this is an OCT that we'll end up seeing post-cataract surgery in a diabetic patient, and sometimes we can take different decisions. People are too eager to be either injecting or observing. So, what should be the ideal way to approach a case like this?
That's what I'm saying. Either it was already a pre-existing DME, which worsened further, and that is what we are seeing because it was not looked in. So it's very important these days that we must rule out that. In case there is a DME, I think it's very important that we have to manage that, as I mentioned earlier. So in case it has come to this stage, so you have both the choices. Since the cataract surgery has already been done, now you could use anti-VEGFs, but then you will have to use monthly anti-VEGFs, or this is a pseudophakic eye, even if there are no issues and the IOPs and other things are normal, you could give a very easily Ozurdex in an eye like this because that will take care.
Correct. Yes. So I would also like to highlight this point that sometimes we need to differentiate the diabetic macular edema with pseudophakic macular edema as well. And this is where the foveal cysts become more important to be seeing. It's not just the retinal thickening, it's the foveal cysts. And along with it, you need to see the fundus as well. So having a fundus, just not an OCT, because the fundus evaluation is important to see if there are any microaneurysms, any hard exudates, to differentiate it from a pseudophakic CME.
Exactly.
In which
I think even the pseudophakic CME can present just like that, the way this is. Suppose there is no retinopathy, or you don't see anything in the other eye, then I would just treat first this kind of a case with topical NSAIDs as well as steroids. For 3 weeks course we usually give 3 times a day, like mostly something like whatever we give, Predfort or Novanac or whatever we like, 3 times a day for 3 weeks. Most of the times it will start reducing by that time. And if it is reducing, you continue with that. And many cases, at least in our own practice, 70 to 80% resolve with this kind of a treatment. It's only a smaller number where you may require further intervention.
Correct. So maybe those smaller number, what would be the option? Because this was that patient who had persistent pseudophakic CME for about 4 to 5 months.
Yes.
So what would be your first line of treatment in such patients, sir?
I think this is one indication where perhaps we can even try periocular steroids, so that we do try in the pseudophakic CME cases before we go on to like injecting really intraocular injections. Okay. So that can be tried.
So I think, sir, in our case, this was managed by 2 of our colleagues. This patient who came 5th month post cataract surgery, we did go ahead and give an IVTA actually. So this is why I was wondering what would be your choice. In our case, we chose IVTA. Although it was more invasive, according to you, we could have probably tried PST, like a posterior subtenance, but this is what we chose. So just to highlight this point, sir, I thought that 2 different patients of diabetic macular edema and pseudophakic CME, the incidence is still less, but it peaks, like you said, about 4 to 6 weeks. And in diabetic patient, it has 4-fold the risk. And the incidence is higher if there is pre-existing DR and previous DME. So I'll just conclude with just a few takeaways, sir, that we should actually dilate all cataract patients, ensure that we take an HbA1c, and to what sir added, a 24-hour urine protein, a pre-op OCT for patients who we suspect to have CSME or DME, or when vision doesn't correlate with the cataract grade, differentiate pseudophakic CME and progression or worsening of DME, so that the agents that we choose can be varied, like a topical NSAID or IVTA, and when in doubt, obviously take a second opinion from a retina colleague. That would be it, sir. Thank you so much.
Thank you. Thank you, sir. My question is that whenever the candidate this type of macular edema, here there are so many